Transperitoneal approach is sometimes indicated when there is a collection anteriorly, or there is indication for anterior fixation where the posterior element of the lumbar spine are not stable enough to do fixation. It can be also indicated for a listhesis, and the basic approach is that the patient is positioned on a lateral side. We prefer to go on the left side because aorta is more resistant to inferior vena cava for injury. Go external oblique, transverse abdominis, and internal oblique muscles. We go to the go through the dissection, sweep the peritoneum towards the other side, or we can go transperitoneal if we prefer to dissect. In that case, we will extend the incision into the peritoneum, pull viscera to the other side, push the viscera to the other side, and then give a nick in the peritoneum and reach the spinal canal, the vertebral body. The risk of the surgery with the anterior approach is that the sympathetic change is anterior to the vertebral canal. There is aorta, genitofemoral nerve, and ureter, as well as superior hypoglossal plexus, which, if injured, can lead to retrograde ejaculation and sexual dysfunctions. I was asked about a question regarding approaches, and while talking about thoracic spine, I was asked a transthoracic approach. So a transthoracic approach is basically an approach to the spine at the thoracic level. As we can understand that the thoracic segment has 4 supportive structures, with the rib cage and the sternum as a 4th segment. So any approach which is transthoracic approach goes to thoracic spine from the thorax, and it can be done for fusion, decompression, discectomy, or deformity correction. I will position the patient and lateral on a table which can break, making understand the fact that for the upper thoracic spine, that is T2 to T9, we prefer to approach from right side to avoid the heart and aorta. For the thoracolumbar junction, we try to approach through the left side to avoid the liver. And in convexity, I will approach towards the in the scoliosis, I will approach towards the convexity. A double lumen ET tube will be placed for a single lung ventilation. I will give incision over the rib cage, extend the dissection to the lateral border of rectus femoris, rectus abdominis. Dissection will be muscles splitting the fibers of latissimus dorsi and serratus anterior. I will divide latissimus dorsi in the direction of incision. I will enter the chest space via intercostal space, or I can do a rib resection. I will incise the pleura, expose the lung and diaphragm, deflate the lung, incise the pleura on the other side over lateral border of oesophagus, retract the oesophagus to the other side, and then sweep the peritoneum like gate vessels and approach the spine.